Hello everybody, this is Dr. Ahmed Amin Nasser. Hypnomorpheus is my new site that I am currently developing to talk anesthesia as we do it. No sophistication, no academic complexities, only simplicity is promised. Hypotension under anesthesia could be time differentiated into post-induction hypotension, PIH, and intraoperative hypotension, IOH. It could be associated with hypoperfusion of tissues leading to ischemia as acute kidney injury, stroke or transient ischemic attack, delirium, and myocardial infarction. Its prevention and treatment is central to anesthetic management. The prevalence of PIH varies significantly between different studies, with no unified criteria of its level. PIH reported to be from 9 to 60%. For the time being, let us stick to a map of 65. However, you are free to choose what is appropriate for your case. Here I will take the chance of introducing what I call 3-2-3 anesthesia, a simple way to describe our situation here. You start by a 3-figure systolic that becomes 2 figures after anesthesia hypotension. Then, following a vasoconstrictor, systolic becomes 3 figures again. Hence, 3-2-3 anesthesia. If repeated, it's going to be 3-2-3-2-3 anesthesia, also known as roller coaster anesthetics. Hypotension occurrence is determined by disruption of either systemic vascular resistance or cardiac output. And of course, cardiac output includes stroke volume and heart rate. In simpler words, PIH could be caused by anesthesia-mediated vasodilatation or cardiac depression. It's not rocket science to assume that anesthetics are the main culprit of PIH. Propofol is so notorious for that. But it is forgiven, as we are going to live with it very long time. High-dose fentanyl does the same. However, we're going to leave that for cardiac anesthesia. There are patient factors facilitating anesthetics, like aging patient. It's a prime example of that. Age-induced atherosclerosis render vasculatures hypersensitive to anesthetic vasodilatation, and more importantly, facilitate ischemic effect of hypotension. Sick patients, ASA 3 or 4, and emergency cases display marked vulnerability to hypotension, having very high stress response level, leaving little or no reserve to counter-effect anesthetic-induced hypotension. That's where you will get 3-2-3, 2-3-2-3 anesthesia, or even 3-2-2 with a downward spiraling. If there is a factor that could be singled out causing PIH, it certainly would be low blood volume. Dehydrated over compliant patients with long fast or patients with leaking capillaries in early septic shock are cases of PIH that, in spite of treatment, would degenerate into early intraoperative hypotension. Anesthesia is almost 3-2-3 or even 3-2-2 that could prove fatal. ACE inhibitors or angiotensin receptor blockers out of all drugs, are so notorious of causing resistant PIH. No wonder they are blocking the basics of pressure control. It is in fashion to stop it day before surgery, which unfortunately might get into hypertensive situation where 2-figure diastolic pressure becomes in 3 figures, leading to what I call 2-3 cancellation or 2-3 dangerous intraoperative withdrawal hypertensive reaction. Personally, I don't recommend stopping it, and I find ketamine induction and calcium could help. 3-3 anesthesia could be ascertained by volume replacement as an essential remedy for dehydration. Don't get intimidated by how much volume needed. From 0.5 to 3.5 liters could be required. Well, if worried, think of stepping up monitoring to CVP. Get away from the one and only propofol if you could. Instead, proactively prevent highly probable PIH through cardiostable anesthetics like etomidate, ketamine, or propofol or ketofol, which even if it failed to prevent PIH, it would certainly make it transient and easily treatable. Believe me, there is always time for volume replacement besides head-down position. Don't underestimate such maneuver. Metaraminol vasoconstrictor of choice for short-term management, especially with tachycardia. Ephedrine, especially with bradycardia, as it is both vasoconstrictor and cardiostimulant. A touch of glycopyrrolate could nudge the heart rate and correct hypotension. Phenylephrine alpha agonist is found to be useful in obstetrics as it results in minimal acidosis of fetal cord blood. Now, with combined regional and general anesthetics, probably infusion is superior to boluses. Whatever you do, take care as you reach the second or third bolus or high-level infusion. Think of invasive monitoring and stepping up vasoconstrictors to noradrenaline. Also, beware, vasoconstrictors in excess could compromise coronary circulation. The good news is that PIH is less significant than IOH regarding post-operative organ underperfusion, probably because of prolonged nature of IOH. Routinely ask in every list of cases which patient is a candidate for PIH and work proactively. Anyway, remember, our first maneuver is volume infusion. If your assistant gets PIH and calls for you while you're having your first sip of your coffee following induction, then there is an issue, as it was not expected, hence was not faced proactively. In a very busy list of short cases, and shuttling back and forth from induction room to operating theater, if you were startled with a hypotension reaching the floor, there is an issue here as well in your proactive management that you have to resolve. Make sure do not attempt anesthesia before correcting dehydration or hypovolemia. Best anesthetics will put patient to sleep with an enough degree of vasodilatation to decrease after load, augmenting cardiac output. Practically improbable. Try to customize your anesthetics and carefully monitor your patient. Bradycardia or lowering end-tidal CO2 are of very sinister effect. They denote cardiac depression and lowering cardiac output, and makes it urgent to tackle the hypotension the right way. Let me conclude. Volume replacement and graded monitoring are mandatory. Be on the positive side of life and look at PIH as a harbinger of IOH, and take all your measures for preventing and treatment. Thank you.